Good afternoon to all of you, and welcome to the Rakesh Mathur Awards for Research, for Excellence in Research. The first speaker under the aegis of the H.H. Mathur Award for Research Excellence in Applied Science is Dr. Rinti Banarjee, who is the head of the Biosciences and Bioengineering Department, and also the Madhuri Sinha Chair Professor in the same department. Rinti completed her MBBS in 1996 and then came to do a PhD at IIT Bombay in biomedical engineering, completed that program in 1999. It's not often that you find medical doctors in this country doing research. Subsequent to finishing her PhD, she went to the University of California in San Francisco, did a 2-year postdoctoral stint, came back in 2001 and joined as a faculty in our department. Rinti's broad area of research is in nanomedicine, specializing in designing smart biomaterials for drug delivery in a number of human ailments. She has published over 100 research papers in international journals. She is a member of numerous societies and is on the editorial board of a very long list of journals. I won't list all these accomplishments because then in that case, I would probably talk longer than she would. Nevertheless, I'll just give you a sampling of a couple of her achievements that illustrate a long list of. So she's a member of the DBT, Department of Biotechnology Task Force in Bioengineering. She's on the advisory committee of the Bill Gates Research Foundation. She's on the editorial board of Nature Scientific Reports, and is on the editorial board of Drug Delivery and Translational Research, a Springer Verlag publication. It is my pleasure to invite Professor Rinti Banarjee to deliver her talk on smart biomaterials and drug delivery. Rinti?
Thank you. Professor Rao, your introduction by you makes this even more special for me. A very good afternoon to all of you. It's actually an absolute honor to be here to share some of our research work today with all of you. And before I talk about the areas of research that we have been working on, I also wanted to give a little overview about what motivates us to do what we do. And you heard a little bit from Professor Rao about the journey, so I also want to tell you how it all began. And then, of course, we'll get on to the formal talk. So the first thing is that the motivation for me and everyone in my group has basically been to look at technology development for an unmet medical need. What we mean by an unmet medical need means that there is a condition where the current therapy is not effective in that condition. So there's no known treatment for that disease. So all those categories come under the unmet medical needs. The second category is that of affordable quality. Means that there is a treatment available for a particular condition, but it is very expensive and hence out of reach for a large amount of the population. And so can we increase the reach of those medicines by improving the technology for affordability while maintaining or improving the quality? And then the third category is reduction in toxicity, which means that there is a drug, it has its effects, but it has so many off-target effects that the side effects are cumulative and limit the usefulness of the drug. So in this category, the technology is aimed at reducing these off-target effects so that the toxic effects are reduced. And then the last category is that of improving patient compliance. What this means is, how do you make a particular drug more reachable to the patient. For example, if it is a needle-free administration, the chances of the patient taking it regularly over a longer period of time increases much more. So can we take things which are normally given intravenously, intramuscularly, and design delivery carriers so that they can be given through the skin, given orally, given without the need for skilled, trained manpower to actually administer these drugs. And also ease of use, meaning that instead of taking something 3 times a day or 4 times a day, can we do it once a week, once a day? These are things that in long-term diseases aid in the compliance, and hence the patients take those drugs more frequently in the correct amounts required. And how do we do this? We do this by packaging these drugs in various carrier materials, and those materials need to meet certain criteria. First of all, they need to be safe. So the material which you're using as a carrier should not add any other toxicity to the overall system. Second, it has to be biodegradable. What this means is after the job is done, that material should be broken down by enzymes and other systems within the body so that it can disappear without causing any long-term side effects. And the third is the concept of a smart material, which is the same material should have the ability to change its phase so that it can behave differently under different stimulating conditions. And I'll talk a little bit about that. So just to give you a brief introduction of how I got here. So at the very beginning, as Professor Rao mentioned, medical doctors very rarely get into research in our country. So I was happy doing medicine until I came across a problem associated with premature babies. These babies are born before term, and hence their lungs are not yet mature. And these lungs do not have a substance which is known as pulmonary surfactant. It is a complex mixture of various kinds of lipids and proteins, and it acts to reduce the surface tension at the air-liquid interface in the air sacs. The air sacs are the smallest units inside our lungs. And because this substance is not present, these babies have respiratory distress. And you may have heard that these babies are then transferred into incubators or given positive pressure ventilation. So it started off with the query that why can't this be addressed by replacing a mimicking material which will function like the natural one and given a surfactant to the babies rather than transfer them to these ventilators and cause high amount of neonatal mortality. And in quest of that question, I landed up in IIT Bombay, and as it seems that the answer to this was an interdisciplinary one, which lay in the Langmuir-Blodgett films which are associated in the thin films lab of the physics department, and the microstructure of vesicles associated in the chemical engineering department silicate technology lab, and finally the biorheological sort of evaluation with mucus, which was associated in the biomedical engineering lab. And so that is how I came here into IIT Bombay. And I'd like to thank IIT Bombay to have the open environment to allow people of various backgrounds to pursue this kind of interdisciplinary research in innovation. So now getting to the talk, what I'm going to talk about today is first give you a concept of why we need drug delivery carriers and what kind of materials can actually be used to design these carriers. And then the concept of what is called as a trigger responsive platform or a smart material, where the same material should change its phase and hence act differently under different conditions. And then I will be talking about 3 broad platforms. The first one being needle-free delivery, which means how can we make these particles such that the drugs can be given as aerosols and go into the deepest parts of the lungs without requiring intravenous injections. And the second, the oral core shell nanoparticles, which are for drugs which normally do not get absorbed orally and have to be given as injections. Why? Because these drugs get broken down by the environment in the stomach. So how do you protect them such that you enhance the absorption through an oral route? And then looking at additional barriers which prevent the reach of conventional drugs in certain sites. One example here is to exploit transdermal delivery. Transdermal means delivery through skin. The skin is extremely available, and yet we have very few drugs which we actually take through the skin. So there are reasons to that based on the barrier of the skin, and we look at how we can address those. And then intranasal and ocular, these are to try and reach the back of the eye, diseases of the retina, and secondly, diseases of the brain. To date, it is very difficult for drugs to cross and reach the brain, and hence there are certain barriers which actually are protective for us. But when we want to deliver a drug, we need to find a way to be able to pass through those barriers. And so we talk about how you can go through the nose into the brain for delivery of drugs. And the last category is that of nanoparticle in situ gel. What is an in situ gel? This means that these particles are now suspended in a biopolymer. This is in a liquid state when it is instilled, and hence you can give it as an easy injection. But when it is at the target site, because of temperature or ionic changes, it then forms a three-dimensional meshwork with gel. And hence this will form a depot to allow regional delivery. And so this can have various applications. Intravesical means trying to deliver drugs into the urinary bladder. As you can imagine, the presence of urine will wash out any drug that's present in there. Intra-articular, meaning delivery of drugs to the joints. And finally, to look at these as scaffolds, which will augment the cells and tissues to regenerate themselves. So first of all, what do we mean by drug delivery, and what are these drug delivery carriers? I like to talk about the conventional letter in the postal system before the email days. So the drug is actually like the letter, and it has to reach only its recipient. It is not okay for pieces of the letter to reach everybody else prior to reaching the recipient. In the same way, the drug always has a target site, and that target site is where the drug has its action. Till it reaches the target site, we must protect that drug, and hence the envelope is acting as this role. So the drug delivery carrier is like this envelope where it has to protect the drug till it reaches the target site. And along the way, it has various ways of knowing what is the address or where is this particle designed to go. And then finally, at the site, the letter has to be openable. And hence, this carrier must now be able to leak out the drug. And hence, we have this opposing criteria of having an increased rigidity and protection prior to reaching the target site, and then an increased leakiness to reach out the drug at the target site. And that's what we want to do by various smart materials or phase change materials. So just to give you examples, basically when you use amphiphilic moieties, these have a hydrophobic end and an hydrophilic end. They could be lipids, polymers. They then tend to self-assemble depending on their microenvironment. And in this example, you see that various kinds of structures can be formed by these lipid bilayers. So the simplest amongst them is what is called as a liposome. Here, you form a bilayer of these amphiphilic molecules, and in between, you entrap the aqueous phase. And hence, such a carrier can entrap both aqueous or hydrophilic drugs in between, as well as hydrophobic moieties within the bilayer space. And it is possible for you to have the changes from one type of structure to another. Why do we do these, and why are we at the nanoparticle scale? There are certain distinct advantages that we get biologically. Just a few I will show you in this figure. The first one here shows you that this is a capillary, which is a small blood vessel. So what happens is in the tumorous sites where there is a disease, the capillaries have larger spaces between the cells which line them, or the endothelial spaces. These gaps are around 500 to 700 nanometers, whereas in the normal capillaries, these gaps are around 5 nanometers. So if our particles can squeeze through these gaps, they can preferentially accumulate around tumor sites. And this phenomenon is known as the enhanced permeation and retention effect. It allows you specificity of where the drug is going to be delivered. And the next advantage you get is what is called as intracellular delivery, which means instead of delivering drugs around cells, you want to go inside the cell and deliver the drug. And these green are actually cancer cells, and what you see in red are the particles. And so what happens is these cells utilize their own pathways which are meant to take in nutrients and take up the particle. So the job is to package the particles so that it mimics a nutrient of the cell. Then you exploit the cellular pathways to get the particles inside. Without going into details, these can then be blocked by various inhibitors, and hence you will know which type of cellular pathway your particle is exploiting. And hence you have another level of delivery in terms of specificity. How do we get the smartness, or what are the triggers? There are various changes in pH, temperature, enzymes which are associated with various sites in the body as well as various diseases. Now these can cause the phase transition of the material from a more rigid to a more leaky phase, allowing you to have preferential release when associated with these triggers. These are already present inside the body and are being exploited by your carrier, whereas the ones on this side, ultrasound, magnetic field and light, are not present inside the body but are then focused from outside and hence are referred to as external triggers. All of these can then allow you to switch between the envelope closed to envelope open state of the drug carrier. So to give you examples of the platforms, back to the premature baby condition, we were actually able to develop pulmonary surfactant mimetic nanovesicles, which led to 3 Indian patents. And the recent form of this technology has its US patent granted last year. This is an improvement over all the existing formulations because those are given as direct injections into the trachea or airway, whereas this one is given like an aerosol, just like you take asthma medication, and can go into the deepest parts of the lungs. Moving on, we also found that in various adult diseases, the same surfactant is dysfunctional. It's not deficient, but there are conditions like proteins, inflammation, which then prevent it from acting. And hence it is possible to tailor-make this surfactant so that it is effective in other respiratory diseases like the adult respiratory distress syndrome. And this is an unmet medical need. You may have heard of high mortality associated with ARDS or critical care conditions of many of our famous personalities. There's also the concept of trying to have pH triggered aerosols. In this case, you can package these particles so that they are in a lamellar phase and are stable at pH 7 to 7.4, which is the normal pH in the body. And in the disease site, as the acidic pH environment comes in, these then change to an inverted hexagonal phase and cause a preferential release of drug. To show you an example of this, these are 120 nanometer particles of ethanolamine phosphatidyl based particles, and these were delivered as aerosols which have then micro droplets of 1 to 3 micron aerodynamic diameter and can go into the deepest parts of the lungs. So this shows that they are taken up by the cancer cells, and these are the lungs. All the black dots are actually metastatic or cancer nodules. And you see, by giving this aerosol, all of this gets cleared up. And what happens is you get an advantage over that of the same drug, which is in the conventional state given intravenously, because the survival increases. So as the toxicity increases, you get lower survival, and you see here in the growth inhibition index, several fold higher growth inhibition or killing of cancer cells occurs with the particle forms as opposed to the conventional one, which is given intravenously. And a similar platform, but now for 2 drugs. What if there are 2 drugs which need to be delivered, both of which are hydrophobic? Hydrophobic means not soluble in water. So this is a 2-compartment vesicle where there's simultaneous delivery of the 2 drugs, paclitaxel and curcumin. Here you see that the lower IC50 means what is the dose that is required to kill the cancer cells. So the lower the value you get here, the more effective is the drug. And you see, as opposed to the conventional drugs, you have several fold improvement in the efficacy. Once again, these are the tumor loaded lungs. This is the conventional treatment by intravenous route, and this is just aerosols of paclitaxel and curcumin, which can clear up these tumors. What if you have 2 drugs, one hydrophobic and one hydrophilic? So this is the platform where you have a core shell particle. The shell is hydrophobic, which is the lipid based, and the core is a biopolymer alginate. And this can then deliver 2 drugs, one which is attacking the blood vessels associated with the tumor. That's referred to as anti-angiogenic, which means that you're cutting off first the nutrient supply to that tumor, and then you're delivering the drug which is killing the cancer cells. Once again, shown to be several-fold improvement over conventional therapy and has been patented. What about the oral route? Core shell nanoparticles for drugs which cannot be delivered orally. So these are because of low solubility and because the drug themselves breaks down in the stomach, which has an acidic environment. So this is a core shell particle. The core is lipid based and the shell is biopolymeric. This is like a protection while it goes to the gastric barrier, and these particles are both pH and enzyme responsive, associated with the tumor site, which is in this case the triple negative breast cancer. Just to show you the effects, if you focus on these blue bars, you see a large blue bar at the heart for this drug. This is the conventional drug known to cause toxicity in the heart. And the same one, when given in the particle form, the levels in that particular organ come down. And so you can alter the distribution and hence the toxicity. And you have exactly the opposite effect with increased tumor levels when you give these particles orally. And the main complication of anti-cancer drugs, as many of you may be aware, is the fact that it depresses the bone marrow or the blood cells. Because the blood cell count goes down, that limits your therapy. So what we find is that with conventional drugs, as expected, the numbers have declined of these blood cells, but even at 10-fold higher concentrations, you can maintain these bone marrow cells in these particle forms. And you finally evaluate these efficacies in animal models which have human tumors. This is a drug-resistant breast cancer model, this red bar showing you that with that oral particle, you bring down the tumor load and cause maximum 100% survival as compared to all the conventional therapies. Going to an example of an external focus, this is ultrasound. When you have a bubble which is filled with gas, then you can focus ultrasound on these bubbles and cause them to oscillate. Those oscillations can lead to cavitation, which can then cause release of drugs as well as cause what is known as tiny pores or sonopores within the cells to allow drug delivery. So these are microbubble nanoparticle complexes which can be tracked through ultrasound, and then when a focused ultrasound is given, it can cause cavitation and bursting of these particles at the desired site to cause increased efficacy as seen by this red line where you have the lower tumor burden using the ultrasound responsive particles. Fluidizing nanoparticles for enhanced penetration. Can we go through the skin barrier? So in this case, as I mentioned, the outermost layer of the skin is protective and prevents agents from passing through. So our task is to actually cause a fluidization of this barrier temporarily so that the particles can squeeze through the skin. And while we do this, we can actually have different approaches, one going only along the hair follicles, one going through and through the thickness of the skin, depending on how we make these particles. And these have implications in both in dermal diseases and whereas through the skin for the rest of the body. So this is one example where we wanted to deliver nutrients. Iron and folic acid is a vitamin which is required by women, and there's a high amount of anemia, and deficiency of these two nutrients in pregnant women can actually affect the birth of the babies. But there is a reluctance to take these pills regularly over several months because of gastric side effects. So what we wanted to do is try to deliver them in everyday use products. So we use the same technology to pass through and through skin, but at this time these nanoparticles are then within matrices of cosmetics. So various kinds of lotions and skin packs which women can use having these nanoparticles, and they have been tested to show that just by application daily, the levels of these nutrients can come up in a non-invasive manner and have been shown to be safe in skin. We've also been looking at extension of this to drugs in patches for childhood pneumonia. And then to barriers where you cannot actually reach the drug under conventional routes. So the most common there is the brain. No agents actually reach the brain if you just give them intravenously. It's because of this structure here, which is referred to as a blood-brain barrier. This is actually protective because it prevents toxic substances from going in, But when you are designing your carrier to carry drugs, this becomes like a bottleneck. So we use what is called as the Trojan horse concept. Here, these membranes actually have tiny pumps which can throw out any drug which is trying to cross. So these Trojan horse concept is such that the particle is recognized rather than the drug, and hence it sneaks through the side of the pump and gets into the cell, and then after that releases drug into the brain. And it's possible to give this through the nose using the same route that we use to smell. The idea is to use the particles going along those same nerves so that you can reach the brain. Similarly, for the eyes, the back of the eye or the retina is a challenge to reach, which can be done by these nanoparticles. And the last platform is nanoparticle in situ gels, which means that the biopolymer in which the nanoparticles are suspended are in a liquid or solid state, but because of ionic or temperature-based triggers, they form a cross-linked gel, and you can modulate the porosity and viscoelasticity of this gel as required. So one of the main applications here is that in the urinary bladder. Again, a disease of elderly where bladder control becomes a problem. No drugs reach into the bladder. And if you just instill the drug by a catheter into the bladder, the residence time is 2 hours because of urination. So we are able to make these nanoparticles in situ gels which will coat this inner surface of the bladder and then enhance the retention of drug. So in this case, as opposed to 2 hours, we can have the drug levels over a week or 2 weeks within the bladder without causing systemic toxicity. This is the wall of the bladder with the coating of the gel, and this red color shows you that the drug from this platform actually passes through and through the bladder wall, and hence you can use this as a platform for various different technologies of bladder diseases. Going on to intra-articular therapy, this is where in the joints we want the drug to be residing, and hence we can modulate the retention of the drug within the joint. And then we can also not just give drugs but give growth promoting agents so that cells can get trapped within this in situ gel, and then those cells can regenerate. This is known as tissue engineering or an in situ scaffold. So here in arthritis, we address the root cause of arthritis. That is, there's a degradation of the cartilage, which is the soft cushiony end at the end of the bones. And if this cartilage can be regenerated, then you are addressing the root cause of the problem in this condition. So we've developed these nanoparticles in situ gels. We can modulate this porosity, and it actually is bioadhesive. Bioadhesive means it's sticky to the other interface of the tissues. So you can see here, this is the bone and this is the interface where the gel is actually merged with the surrounding structures, and hence this forms a cushion-like matrix and can replace the cartilage function in these joints. Very important because it brings out the possibility of ruling out joint replacement surgeries in this very debilitating disease. And the last example is that of bone tissue engineering, where fractures which are very difficult to heal can again be used with that in situ gel, but this time we use additional nucleating particles which are of calcium phosphate based hydroxyapatite or bioglass. So in this case, over time you will have the mineralization occurring, and you have the osteoblasts or the bone cells getting stimulated, and hence difficult to heal fractures can be cured by this kind of an approach. We like to refer to this as a bone regenerative glue. When there are multiple fractures or pieces of bones, you actually use a glue to hold them together and allow them to regenerate. So what we've been doing over time is developing all these various platform technologies. We have technologies which can achieve site or disease specificity and can have enhanced penetration and access alternate routes of administration which are not accessible to conventional drugs. Where are we at present? So some of these in the skin segment have actually been commercialized, whereas many of the others are being translated along with industry partners for scale up. And along the way, we've got a clearer understanding of material cellular interactions and how to modulate them to our benefit. This does not all the students, it's just a representation, but I'd like to thank everybody who's played a part in this fun-filled journey. So far, students, collaborators, faculty and staff at the department, friends across the departments, and all the funding agencies. Thank you so much for your kind attention.